painkiller addiction is sweeping the nation, especially in Oklahoma. In March of 2008, SAMHSA announced that Oklahoma leads the nation in painkiller addiction. This epidemic is caused by cheap and easy access to these drugs through illicit online pharmacies. The DEA is rapidly moving to shut down such operations. This in turn will cause an onslaught of addicts who have previously been able to manage their addiction, becoming sick and desperate virtually overnight. A foreseeable progression of consequences will overwhelm the criminal justice, healthcare, social, and behavioral health systems. Communities must act now to strategically plan a response before they are overwhelmed. This progression results in worse consequences for individual addicts, their families, and their communities as time progresses without effective intervention. Early detection and effective intervention is key to minimizing damage to people and cost to taxpayers. Steps towards an effective response to this emerging opioid painkiller crisis include, number one, inventorying opioid treatment programs in your area. Not all substance abuse treatment programs are adequate and achieve the best outcomes for opioid addicts. Such opioid treatment programs are SAMHSA certified and accredited. As I said, not all substance abuse treatment methodologies have proven effective with opioid addicts. The Substance Abuse and Mental Health Services Administration, SAMHSA, of the Department of Health and Human Services has done extensive research into what works best, that is, evidence-based best practices. And they've identified that medication-assisted treatment provides the best outcomes. If you need to learn more about medication-assisted treatment, you can go to dpt.samhsa.gov. SAMHSA certifies and accredits opioid treatment programs to administer this best practice approach to opioid addiction. The next thing that we need to do is we need to inventory supportive and wraparound services, which include transportation, child care, etc. The foreseeable progression of consequences includes encounters with the criminal justice system as these addicts seek higher risk and illegal options to satisfy their addiction. Involving law enforcement in the planning of expeditious routes toward treatment rather than expensive incarceration, which does little to promote recovery, is one facet of addressing the problem. Inventorying public defenders and educating them as to this emerging crisis for their own planning is another step. Accessing treatment is also a huge issue. This involves identifying transportation, funding, child care, and financial aid, as well as treatment resources. All of these resources need to be identified, cataloged, and disseminated to the first-line support and care system providers, such as healthcare, social services, and churches and schools. Then we need to anticipate and remove barriers to treatment, identify various at-risk populations. Then we need to imagine ourselves in their position as they attempt to access help. Identify each barrier and generate a plan to remove these barriers or manage around them. Barriers range from practical factors like funding, transportation, and child care, but also include formidable social and psychological barriers that are just as effective in preventing optimum access to treatment. This requires extensive community and professional awareness and educational efforts. We need to further find pathways to easy access or develop these pathways. Having anticipated barriers and identified solutions, we need to organize this work into pathways toward access of effective treatment. Then we need to record these pathways in step-by-step pamphlets with contact and access information made available to those that read them. Then they need to be simple to follow. We need to include pointers on how to talk to addicts who are somewhat ambivalent about accessing treatment, using another SAMHSA best practice, motivational interviewing approaches. If you need to know more about motivational interviewing approaches, go to www.motivationalinterview.org. Finally, we need to educate first-tier providers to the warning signs and referral procedures. We need to take the tools that we've developed to the ones who need them and have the best chance at intervening before much damage occurs. Opioid treatment programs can avoid the bottleneck, great expense, and life interruption of inpatient detox in many cases. If an addict can go directly into opioid treatment programs' outpatient programs, much of their lives can remain intact without expending large amounts of resources. Since OTPs have been proven to have the best outcomes, they make a lot of sense in planning for this emerging opioid crisis. Examples of such OTPs in Oklahoma include the Quapaw Counseling Services in Oklahoma City, 405-672-3033, or you can go to their website, qcs-okc.com, or Quapaw Counseling Services in Miami, Oklahoma, 918-542-1786. Their website is quapawcounselingservices.com. Finally, there is Katua Cherokee Treatment Services in Tulsa, Oklahoma, 918-835-3017. And you can access their website at kctxs.com. To find other OTPs in other states, go to dpt2.samhsa.gov/treatment. There is help for communities. There are help for opioid addicts. We need to start now to organize that response.